Hi, I'm Martha Nance. I'm the director of the Huntington's Disease Center of Excellence at Hennepin County Medical Center in Minneapolis and an adjunct professor in the Department of Neurology at the University of Minnesota. Today I'm going to talk about juvenile onset Huntington's disease, focusing on how this relatively uncommon presentation of Huntington's disease is different from adult onset, and also talking about aspects of diagnosis and management. These are my disclosures. So we'll start by talking about the definition of juvenile onset Huntington's disease, the demographics of the disease. We'll describe the differences clinically between JHD and adult onset HD. We'll talk about diagnosis and management, and I have one slide showing some references at the very end. So we actually, our first challenge with juvenile Huntington's disease is figuring out how we define juvenile onset. There are practical ways to define the disease that primarily are socially based. At what age does a child become an adult legally? In the United States, you could say that that's age 18. The National Institutes of Health actually defines childhood as extending up to age 21. In other countries, the age of majority may be somewhat older, maybe somewhat younger. It's convenient scientifically to cut things off by decades. So loosely speaking, you could refer to juvenile onset Huntington's disease as under 18, under 20, under 21. I tend to use the definition under 18 because of the fact that in the U.S. People reach the age of majority at age 18 and are able to make their own medical and legal decisions at that age. About 5 or 10% of people with Huntington's disease have onset before age 18 or 20, and of those, about 90% have an affected father. Importantly, that means that the other 10% of people with juvenile onset Huntington's disease do have an affected mother. I think sometimes families or physicians worry that it's not possible for a child to have juvenile onset Huntington's if it is a mother who's affected, but that's not the case. 90% have an affected father, 10% have an affected mother. And just as another comment not on the slide, the juvenile HD is equally likely to occur whether the person is a male or female child. So it's not the gender that makes a difference is the gender of the affected parent, but boys and girls are equally likely to develop juvenile onset Huntington's. In part, the early onset age is explained by the size of the CAG repeat expansion. So the mutation that causes Huntington's disease is universally a mutation called a CAG repeat expansion. And we've learned simply by studying large numbers of people who do and don't have Huntington's disease that repeat numbers above about 36 can lead to Huntington's disease, and the bigger the repeat number is, the younger the onset age tends to be. Often repeat numbers in children will be greater than 60. Other people will use a cutoff saying, well, often it's greater than 50. Again, you have to be careful, and I would not recommend defining juvenile HD as a certain CAG repeat number. There are occasional children with onset under age 18 whose repeat numbers are in the 40s. So this can happen. So why is it more likely to occur in an affected father or in the offspring of an affected father? One of the things we've learned, again, from studying families with HD is that the repeat number tends to change as it passes from parent to child. The repeat number tends to get bigger, although, of course, it can get smaller. But the tendency for the CAG repeat number to get bigger is more impressive when the gene is passed on by a father than the same gene passed on by a mother. So a father who has 45 repeats may have a son with 82 repeats, whereas a mother with 45 repeats is likely to have a child who has 46 or 48 or 43 repeats, but is less likely to have a big jump in the CAG repeat number in their offspring. So I would define juvenile HD as simply the onset of Huntington's symptoms, diagnosable symptoms of Huntington's in a person under 18. So how does juvenile onset Huntington's differ from adult onset Huntington's disease? Well, in this slide I actually used, just for convenience, I said under 20 and 20 and over. So even in my own thinking, I sometimes use one definition and sometimes use another. But the obvious breakpoint is juvenile onset HD is children, adult onset HD is in adults. There are some clinical features that are a little bit different in adults and kids. Adults tend to have the involuntary movements, the dance-like movements, the chorea, and may have incoordination, stumbling, dropping things. Children with onset of Huntington's, particularly the younger the child is, are quite likely not to have chorea. They're much more likely to have rigidity or dystonia, posturing, stiffness, and that can also include rigidity in the midline affecting oral motor functions. So drooling or slurring of speech may be very early symptoms, particularly in a young child with juvenile HD. In terms of the cognitive disorder, we often refer in adults to the changes in executive function, the decision-making, multitasking, prioritizing, the kinds of functions that executives have to do. Children, of course, are being tested constantly in the school system, and so often the earliest hint that a child is developing Huntington's disease is when there's a fall off in their performance at school. Whatever grades they typically used to get, all of a sudden there's sort of a decline in the performance. Obviously, this can occur in children for many other reasons besides Huntington's disease, and we'll talk about this in a little while, the challenges in making a diagnosis of Huntington's disease based solely on the cognitive disorder. The psychiatric and behavioral disorder is sort of the third part of the triad of symptoms in Huntington's disease. In both children and adults, there's a wide range of behavioral or psychiatric features that can be seen. There's not a single psychiatric symptom that is required for the diagnosis of either adult or juvenile onset HD. But in some children, particularly adolescents who are developing the onset of Huntington's disease, there can be very severe behavioral problems. I called it antisocial behavior, which isn't really a good psychiatric term. I'm not using it in a formal psychiatric way, but very severe behaviors such as burning down the school building, which is what one of my kids was doing, drug or alcohol abuse in a pre-teenager. So when Huntington's disease presents with behavioral symptoms in an adolescent, these symptoms are often quite severe. Depression can also be seen, anxiety, obsessiveness, all the psychological or psychiatric symptoms that we see in adults can also be seen in kids. So other features that are a little bit different between adult onset Huntington's and juvenile onset Huntington's disease, we often see weight loss in an adult with Huntington's disease. This can occur at any point along the way. And in my view, maybe is a little less likely to happen in a child with Huntington's disease because there's someone else in charge of making sure the child eats. So parents will make sure their child is well fed, where an adult with the onset of Huntington's, particularly if they're living alone, they may forget to eat, they may not have money to buy food, and so may tend to lose weight relatively earlier in the disease, where a well cared for child the parent will make sure that the child is getting well fed. On the other hand, seizures are something that's somewhat more common in juvenile onset Huntington's disease and pretty uncommon in adults with HD. Seizures are said to occur in approximately 25% of children with Huntington's. They range from a fairly mild problem that's easily managed to very severe seizures that may require the help of a pediatric epilepsy specialist to manage. There have not really been good detailed studies of seizures in children with HD. The level of study that has been done is mostly just looking at phenomenology, the presence or absence of seizures. Often they're generalized seizures, they may be myoclonic, but really detailed work on electrophysiology or response to medication has not been done. The course of Huntington's disease is said to be a little bit shorter in children than in adults. We often talk about a course of 15 to 20 years in an adult, and maybe more on the order of 10 to 15 years in a child. And shorter, probably the younger the onset age, the shorter the course tends to be. That being said, I have a number of patients that I follow in my clinic who had onset in their late teenage years who are living well into their 30s. I want to comment just briefly about a variant of Huntington's disease known as the Westfall variant. The first description of this variant was attributed to the German pathologist Westfall, who was writing in the late 19th century. He was describing the initial presentation of Huntington's disease with rigidity rather than chorea in a person who is a young adult. Interestingly, he actually did not know at the time that his article was written that he was describing a person with Huntington's disease. That little piece of the patient's history was only learned later on. So the Westfall variant is the name that has been applied to adults who seem to have more rigidity from the onset of their disease and not so much chorea. Some people use the term Westfall variant also to refer to children who have rigidity at the onset of their disease. So there's some dispute or discussion as to which subgroup of patients we should apply that term to. I tend to reserve the term Westfall variant for adults with rigidity, and I just use the term juvenile HD to refer to kids with onset of Huntington's. Interestingly, the Westfall variant seems to be more common in women than in men, and there's at least one pathological study that suggests that rigidity may correlate with loss of neurons in the globus pallidus interna, which in most adults is preserved until somewhat later in the course of the disease, with the globus pallidus externa being impacted earlier on. So that's just a sidebar about the Westfall variant. I ordinarily don't use that term in referring to children, but some neurologists might use that term. So how do we diagnose juvenile HD? Well, just as trying to make a diagnosis in an adult, you listen to the history. You typically hear a history of decline in cognitive or motor function. In a child, that will take the form of declining academic performance at school. It may take the form of declining athletic skills. So my child used to be riding a bike, and now he's having more trouble with his balance. He used to be the first kid selected to be on the relay team, and now he's one of the last kids they pick. In a very young child, where you're really looking at developmental milestones, you may see that the child is failing to achieve developmental milestones at appropriate ages. There's the possible history of behavioral or psychological or psychiatric symptoms, depression, which again can be quite severe, including suicidality, the antisocial behavior, as I suggested earlier, which can be very severe, substance abuse, in an adolescent, inappropriate sexual behavior. And of course, it's very helpful if you have a family history of Huntington's disease. One would expect that there should be an affected parent, or at least an at-risk parent. Every so often, there will be a situation where the child is developing symptoms even before the parent is diagnosed. Other situations where a child may show up with symptoms of juvenile HD without an affected parent would be in the case where there's non-paternity. So the social father is not, in fact, the biological father, and the child may not know that. Or in a situation of adoption where you may not know that there was a family history of Huntington's disease in the child's birth parent. So in the clinic, how would the neurologist recognize features consistent with juvenile Huntington's disease? We tend to focus on the motor exam as our most helpful tool in the clinic. We look for abnormal eye movements. We look for the dysarthria, the oral motor dysfunction. Oftentimes you'll see increased muscle tone or rigidity, brisk reflexes, abnormal gait and balance. Some children, again very young children, may be toe walking or have poor tandem gait, or again, depending on the age of the child, may have difficulty standing on one foot. You can certainly do an office cognitive examination, or look to your neuropsychologist to help with formal neuropsychometric testing. I think it's particularly helpful, and I'll emphasize this in a minute, to have serial testing. So however well the child performs one year, if you test them the following year, are they staying the same? Most kids gain skills as they age. So if you have a child who's actually declining on a formal neuropsychological test, that's a red flag that something is going on. An MRI scan may be useful. Again, in a disease that may progress a little more quickly, may have a little heavier brain changes at the onset of clinical symptoms. You may actually see caudate atrophy on the MRI scan. You may actually see diffuse brain atrophy, which would obviously be abnormal in a child. And there is some suggestion that in very young children, there will be noticeable effects of this disease on the cerebellum, both clinically and radiologically. This is, again, something that's somewhat different between juvenile HD and the more typical adult cases. So again, neuropsychological testing can show frontal or prefrontal dysfunction, declining IQ, or other tests over serial testing. Obviously, you can see all those things in a child for reasons that don't have anything to do with Huntington's disease. There are other diseases that can come on during childhood. The most likely problem in a child who is showing all these findings and has a parent who has Huntington's disease obviously would be the onset of juvenile HD. You can confirm that clinical diagnosis with a gene test. And as I suggested earlier, there's not a hard and fast CAG repeat number that proves that the diagnosis of Huntington's disease is correct. And this is one of the things we struggle with in the clinic. We would like things to be black and white and to say you can only have juvenile HD if you have 60 or more repeats, or if you have 50 or more repeats. It is possible to have onset of Huntington's disease as a child and have something less than 50 repeats. The more common situation, though, would be a child who's 12 years old, has symptoms that look like Huntington's disease. You do the gene test, and they've got 52 repeats. So most patients with juvenile HD will have repeat numbers 50 and above, but you can't be 100% sure that it isn't Huntington's disease yet if the repeat number is less than 50. So the challenges, and I've already mentioned a number of these things, but I really want to reiterate this because it's a difficult thing in the clinic, and patients and families and doctors often struggle with each other as we're trying to do what's best for the child, make an appropriate diagnosis, but not too soon and not too late. So what are some of the challenges? Well, there are many other reasons for a child to have developmental delay. Attention deficit disorder is very commonly diagnosed. Does that diagnosis in a child who comes from an HD family, does that mean that the child has Huntington's disease? Well, no, it doesn't. But it certainly could be seen in a child who ultimately develops Huntington's disease. Another challenge is if the family history is missing or absent or misleading. So in the case of non-paternity. What if it's the mother that's affected? Again, I mentioned way back at the beginning of this talk that 10% of children with juvenile HD will have an affected mother. So that doesn't rule out the possibility of HD, but it may make some people think it's somehow less likely. What if the presentation is behavioral? And this is what we really struggle with in the clinic. Parents bringing their 13-year-old child in. The child is living in an HD family with a father who's affected with the disease and is either having his own behavioral problems or maybe has moved out of the home to a nursing facility. This is a family under stress. And the mother brings the child in because he's misbehaving. And we all, I think, struggle to make a diagnosis of Huntington's disease solely on the basis of a child who's misbehaving without any motor symptoms. But we are learning that the behavioral symptoms may precede the motor symptoms by several years. There are also findings on exam that may be normal in a child of a certain age, but are not so normal as the child ages. So for a child to hold their hands out and stretch the fingers out, the fingers may wobble a little bit in a young child. But by the time you're 15 or 18, that shouldn't be the case. Well, in somebody with Huntington's disease or at risk for Huntington's who holds their hands out and has wiggling of the fingers, that may be one of those subtle symptoms of chorea, mild chorea. So does that, but you would interpret it differently in a young child. What about CAG repeat numbers under 50 or under 45 or under 35? We occasionally see children that have what looks like onset of a movement disorder or certainly onset of behavioral symptoms, and somebody did a gene test and the repeat number is 43. That's a challenging situation for even the Huntington's disease expert, and probably requires careful thought from somebody who really subspecializes in Huntington's disease. And there is the potential, it doesn't happen very often anymore, of a false negative gene test result. The test that they commonly do in the clinical labs has the potential to miss a very large CAG repeat expansion. The test is optimized to see repeat numbers in the range of 10 to 100 repeats. So if your child had onset at age 2 or 3 and actually has 150 CAG repeats, that allele, that gene, may not be identified on the gene test, and the lab may incorrectly report that the child has 2 normal genes that have the same CAG repeat number. Not very common, but again, points out the importance of talking to the lab if you get a test result that doesn't fit with your clinical impression. So we talked about some of these challenges, and I think for the physician, there are risks in either direction. If you fail to diagnose Huntington's disease appropriately in a child, you're sort of missing out on helping the family through the course of the disease, helping them understand the prognosis, the course, making sure they're making appropriate arrangements in terms of their schooling, in terms of the long-term care plan. So you don't want to fail to diagnose HD. On the other hand, if a 13-year-old is misbehaving a little bit and has a gene test that shows 44 repeats or 41 repeats, and you, the physician, don't really think that once you put all this together, 41 repeats is more likely to be a CAG repeat number that leads to onset in mid-adulthood. So now you have essentially a predictive gene test in a 13-year-old who's just misbehaving as some 13-year-olds do, even without Huntington's in the family. So you, the physician, may think that the gene test doesn't have anything to do with the symptoms. There is a tendency for patients and families to start the clock ticking as soon as they have a gene test and to over-attribute symptoms to Huntington's disease. So now that you have that genetic diagnosis of HD, the child, the parent, the school, the siblings, the classmates will all blame everything that happens to that child forevermore on Huntington's disease. So there can be problems on either end, and I hope that we can find what I call the middle ground. I think if a parent has real concerns about their child, that the child should be evaluated by a neurologist with a formal neurologic exam. If it's normal, that's wonderful. Then you have a baseline neurologic exam. I think in a child it's reasonable to do brain imaging. You might just pick up on caudate atrophy. You might see cerebellar changes, particularly in a very young child. And any appropriate lab work, whether it's thyroid studies or just a blood count, routine lab work. I think these children should have a formal cognitive assessment, formal neuropsychological or psychometric testing. Again, that serves as a baseline for comparison in the future. If the symptoms are behavioral or psychiatric or psychological, get those symptoms evaluated, get them treated. Oftentimes children from an HD family are under stress. They have an affected parent. They're trying to grow up in a family with this awareness as they age that this is a disease that may impact on them someday. They're dealing with declining function in the parent. The other parent is stressed. Kids at school have no idea what they're talking about or what they're going through. So this is a kid who's likely under stress. Address the psychological symptoms, address the psychiatric symptoms, optimize the family situation, whether it's through psychosocial interventions, make sure the child has a safe haven at school. This can be really important. If the home is not a good safe haven for the child, maybe the school can be. Is there a teacher, a counselor, somebody at the school who can really work with the child? And then I think it's important to reevaluate the child in another 6 to 12 months. And if there's a sense that the child has declining cognitive function, declining motor function, despite everybody's best efforts to optimize the psychiatric, behavioral, school, social situation, then you might consider doing a gene test at that time. I usually do not do a gene test on day one, the first time I see a child, unless the diagnosis is extremely clear-cut just on a clinical basis. But the middle ground would be evaluate the child and then reevaluate in 6 to 12 months and consider doing a gene test if you can document a decline at that point. So now we'll shift to the management of juvenile onset Huntington's disease. In one of my earlier presentations, I talked about the management of HD in general. And the management of juvenile HD, like the management of adult HD, is best done by a team. It's very hard to do everything just as the physician. The physician, of course, plays an important role as sort of the team leader, managing the movement disorder, writing prescriptions for medications for seizures, initiating referrals to the physical therapist or the speech therapist. If the child is having psychiatric or behavioral symptoms, you may really need to get an experienced pediatric psychiatrist involved. The family may need counseling. The child may need counseling and support. So a psychologist, neuropsychologist, speech, physical, occupational therapy. The rehab therapies have a very important role to play in optimizing the child's function at any stage along the way. functional assessments, equipment, appropriate assistive devices for gait. The dietitian can help the family, particularly if there is a problem with weight loss, to make sure you're eating healthy foods, altering the textures of the foods as appropriate as the dysphagia progresses, making sure you're getting high-calorie foods as needed. The social worker is a critical member of the team in identifying community resources and assisting with legal and financial issues. Children have an advantage over adults in that they have a well-established community day program, in a sense, the school system that really is required to provide services for kids. Children with HD need an independent educational program. I often find it's very useful to see children over the summer so that you prepare their independent education program for the next school year. And then the following year, things will probably have changed. They need a new program. They may need more help. They may need a personal care attendant or an aide with them in the school. They may need changes in the physical education classes. They may need special classes in terms of academic classes. So you can work with the school and the teachers to provide appropriate activities for the child in the school setting. Again, you should not neglect age-appropriate pediatric care just because the child has HD. This is a disease that's going to go on for 10 or 15 years. They need appropriate care. The dentist needs to provide age-appropriate dental care. And again, I often emphasize the role of the lay organization, the support community. Kids in particular like to find each other on the internet. There are organizations and websites that focus particularly on education for children, both children with HD and children at risk. One such youth organization is called HDYO, the HD Youth Organization. They have a wonderful online presence with information for kids. So just to end with some references, there was a handbook written a few years ago, published by the Huntington Society of America, called the Juvenile HD Handbook. And then I've also listed a couple of review articles about JHD. So thank you for listening to the presentation on juvenile Huntington's disease. And we look forward to improved care for this very difficult manifestation of the disease.